sistem terapinya, ya. Jadi saya undang Dr. Samuel Kelvin Ruslim sebagai seorang radiasi onkologis di RSUD Tarakan dan juga di Rumah Sakit Abdul Wahid Tahrani Samarinda. Silakan Dr. Samuel Kelvin Ruslim.
Oke, selamat siang. Semoga Bapak Ibu sekalian belum ngantuk. Gak apa-apa ya, saya bawa dalam bahasa Indonesia ya. Oke. Pertama, perkenalkan saya untuk memperkenalkan bidang saya. Saya seorang radiation oncologist dan perannya dalam pengobatan dalam pengobatan kanker, di mana terapi radiasi itu salah satu terapi utama dalam pengobatan kanker yang kita bisa lihat dengan menggunakan dua teknik, yaitu teknik yang disebut sebagai eksternal, yang kita gunakan dengan menggunakan linek atau menggunakan kobalt, walaupun sekarang sudah jarang digunakan. Dan yang terakhir adalah menggunakan brahiterapi yang dulu disebut sebagai internal radiasi, tetapi untuk mencegah kebingungan antara radiasi internal dengan brahiterapi, maka dia akan disebut sebagai brahiterapi. Oke, pengobatannya bisa dalam berbagai macam faktor. Kita bisa menggunakan dalam setting paliatif maupun setting kuratif, dan berfokus pada kontrol lokoregional. Oke. Nah, kalau kita perhatikan dalam terapi radiasi, semua ini bergerak berdasarkan perubahan dari kemajuan teknologi dari radiologi itu sendiri. Kita perhatikan dimulai dari tahun 1940 itu kita mulai dengan teknik yang disebut teknik 2D atau dua dimensi, lalu berkembang jadi teknik 3D, lalu berkembang jadi teknik IMRT dan VMAT di mana kita bisa mengontrol dosis kita pada daerah yang kita inginkan. Lalu ada teknik IGRT di mana kita berfokus pada organ-organ yang bisa mengikuti pergerakan dari pasien atau pergerakan dari organ itu sendiri. Lalu sekarang berkembang ada yang namanya partikel terapi seperti proton. Lalu sekarang sudah mulai berkembang penelitian seperti neutron. Makanya sekarang kalau kemarin di Korea sudah berkembang seperti BNCT atau boron neutron terapi. Dan juga sekarang menggunakan adaptive radiotherapy. Oke. Nah, apa yang dimaksud dengan teknik 2D? Teknik 3D? Kita bahas dulu dari 2D. Pemikiran sederhananya dari teknik 2D ini adalah begini, bagaimana kita meradiasi organ, di mana waktu itu teknologi belum berkembang, di mana CT scan belum berkembang, lalu kita berharap kita menentukan organ berdasarkan pengetahuan anatomi kita. Jadi seperti misalkan kalau saya mau meradiasi kanker serviks, maka yang pertama kali kita ambil adalah daerah pelvisnya. Nanti kita berharap bahwa daerah yang ketika kita ambil daerah pelvis itu, maka radiasinya itu akan mengenai organ dari serviks itu sendiri. Akan tetapi karena penggunaan lapangan yang begitu besar, maka organ etris yang terkena seperti rektum dan juga bladder itu cukup besar. Lalu kita masuk ke dalam pengetahuan yang ketika munculnya CT scan, MRI, kita mengenal yang namanya 3D conformal, di mana radiasi itu jadi seperti lebih conformal, di mana kita mengharapkan bahwa organ-organ yang sehatnya bisa kita lakukan sparing, di mana organ-organ sehatnya bisa mendapatkan dosis yang lebih rendah, tetapi dengan dosis yang lebih tinggi pada daerah tumor. Lalu kita masuk ke dalam IMRT, di mana kita sudah bisa memanipulasi dosis itu sendiri, di mana kita bisa mengharapkan kita bisa menentukan berapa besar dosis di dalam organ-organ tumornya, berapa dosis organ maksimal yang kita harapkan pada organ-organ sehatnya. Dan juga ketika kita berurusan dengan organ-organ yang bergerak seperti misalkan paru-paru atau misalkan seperti prostat, di mana yang organnya itu bergerak. Oke. Jadi kalau kita perhatikan di sini kita bisa melihat betapa pentingnya imaging bagi seorang radioterapi. Oke, kalau kita perhatikan, di sini, ya, kita bisa melihat bagaimana kita bisa memberikan dosis yang cukup baik kepada organ-organ sekitar dengan mengurangi sparing. Misalkan ini pada kasus head and neck, di mana organ seperti spinal itu kita bisa kurangi dosisnya. Lalu kita perhatikan perkembangan dari 3D ke VMAT, di mana kalau kita perhatikan di situ seperti ini contoh pada radiasi di daerah payudara, kita bisa melihat dari 3D di mana organ-organ sehat yang terkena itu bisa dikurangi dengan pertambahan teknologi seperti pada MRT dan VMAT. Kita bisa memberikan dosis yang cukup tinggi, tetap tinggi pada tumornya, tapi dengan dosis organ sehat yang lebih rendah. Oke, bahkan kalau kita perhatikan di mana kita bisa memberikan penentuan lapangan radiasi yang jauh lebih baik pada imaging yang lebih baik. Misalkan ini kita bandingkan antara CT simulator dengan menggunakan MRI. Kita bisa melihat bagaimana detail dari organ itu lebih baik. Oke, next. Nah, kalau kita perhatikan dasar dari radioterapi itu adalah berdasarkan ICRU yang dikembangkan oleh IAEA, di mana prinsip penentuan tumor itu dari GTV, CTV, ITV. Walaupun saat ini sedang berkembang konsep yang disebut sebagai BTV, Biological Target Volume, di mana tumor itu bukan hanya dilihat berdasarkan imaging saja, tetapi fungsi dari prinsip pergerakan dari biological itu sendiri. Oke, next. Oke, bisa diklik, boleh diklik videonya. Ini adalah contoh bagaimana kita melakukan deliniasi menggunakan PET-CT. Dan ini sudah mulai dikembangkan. Ini saya ambil contoh dari, kebetulan ini dari salah satu center di Tenggarong. Mereka menggunakan, kita bisa menentukan organ sehat dan segala macam, bahkan bisa menentukan daerah tumor yang akan diradiasi berdasarkan penyangatan pada PET. Ini contoh dari MIM. Oke. Bisa dilihat. Ya, itu adalah daerah yang disebut dengan nasofaring, yang kita fokuskan pada kanker nasofaring. Next. Slide selanjutnya, tolong dibantu. Boleh dibantu. Nah, bagaimana peran kedokteran nuklir dalam radioterapi? Hari ini kita berfokus pada treatment planning-nya sendiri. Peran kedokteran nuklir dalam radioterapi terutama untuk pertama memberikan dampak yang berlebih, artinya kita bisa mempunyai kemampuan untuk mendeliniasi target dari sel kanker itu sendiri dengan jauh lebih baik. Artinya kita melihat dengan aktivitas biologis yang bisa kita lihat dari PET-CT, itu akan jauh lebih baik dengan deliniasi dari radioterapi sehingga kita bisa memberikan dosis yang lebih besar. Karena sekarang di era di mana ada adaptif radioterapi, di mana kita bisa memberikan dosis-dosis hipofraksi pada tumor yang bisa jauh lebih besar. Dengan mengurangi dosis, ekspansi dosis yang kita kembangkan, biasanya kan kalau kita menggambarkan dari gross tumornya, lalu kita kembangkan dengan clinical target volume, dengan kita menggunakan PET-CT, kita akan jauh bisa mereduce dari gambaran dari clinical target volume itu sendiri. Sehingga itu berdampak pada toksisitas yang diakibatkan dari radioterapi itu sendiri. Nah, salah satu contoh yang kita bahas adalah saya akan bahas ada 3 contoh yang akan saya bahas penelitian, yaitu yang pertama dilakukan oleh Grabak di Norway. Dia membandingkan 2 penelitian, yaitu penelitian menggunakan radiasi pada kanker paru jenis small cell lung cancer. Yang pertama adalah dengan meradiasi elective nodes, atau kita bilang dengan trial HAS, dan yang satu lagi menggunakan selektif, jadi hanya nodes yang positif yang ditemukan berdasarkan hasil PET-CT. Nah, dua-duanya diberikan radiasi dengan hasil yang sama, yaitu sekitar 45 Gray dalam 30 fraksi. Hasilnya kita bisa lihat, boleh slide-nya? Jadi khas versus tora itu sederhana pemikirannya begini, kalau kita ngeradiasi biasanya karena kita meradiasi lokoregional, maka seluruh kelenjar-kelenjar yang kita anggap positif itu kita anggap sebagai elective nodes. Nah itu kita masukkan dalam lapangan radiasi. Nah yang satu lagi tekniknya adalah kita meradiasi hanya di daerah yang positif berdasarkan gambaran dari PET CT. Sorry. Next slide. Terus udah di bawah ini. Slide nomor berapa ini? Terus ke bawah. Terus. Oke, lewat. Ini dia. Penelitian dari Grabak et al. Dari Norway tahun 2024. Ini penelitian salah satu penelitian yang cukup baru. Next. Nah, kalau kita perhatikan di sini, kita bisa lihat bagannya. Secara overall survival maupun progression free survival, hasilnya tidak berbeda secara bermakna. Bahkan, next slide. Kalau kita perhatikan di sini, gambaran dari toksisitasnya, toksisitas secara akut di grade 3 maupun grade 4 yang saya kasih tanda panah itu kita lihat hasil datanya cukup signifikan lebih rendah dengan menggunakan selective node irradiation. Next. Bahkan ini gambaran dari hasil dari penelitian itu sendiri, di mana kita lihat adanya kita melihat quality of life-nya, dari disfagianya, dyspnea-nya, bahkan secara globality. Kita lihat kelompok-kelompok yang menggunakan, kita memberikan dosis menggunakan PET, itu jauh lebih baik. Karena kita hanya selektif, hanya yang tangkapan positif pada PET CT yang akan kita lakukan secara radiasi. Oke. Nah, penelitian yang kedua adalah penelitian menggunakan pada kasus kanker esofagus. Khusus tumor-tumor untuk T3 dan T4, di mana ini masih pada fase trial 1 dan 2, walaupun ini sudah dilakukan juga penelitian di ESO. Sama penelitiannya, bagaimana kita melakukan terapi pada kanker esofagus dengan hasil yang jauh, secara gambarannya adalah memang hasilnya nggak akan sebagus dengan dosis yang normal, yang kita lakukan terapi secara standar. Tetapi di sini kita perhatikan bahwa dia memiliki long term survival benefit yang tidak dapat tidak bisa melewati dari yang terapi seharusnya. Dan ini hasil ini sudah kita lihat hasilnya sesuai dengan yang didapat pada ESO Shanghai 12, yaitu fase 3 trial. Atau kita lihat pada penelitian dari nasofaring sendiri. Nasofaring sendiri ini salah satu penelitian tahun 2015, ini di China. Mereka melihat dari 3 kasus, di mana yang satu dilakukan terapi hanya konvensional chemoradioterapi, lalu ada lakukan CT guided dengan dose escalation, dan satu lagi dengan PET CT. Kalau kita perhatikan, lihat hasilnya di sini memang sangat menjanjikan sekali penelitian ini. Walaupun menurut saya penelitian ini masih kurang bisa dilihat secara representatif, karena jumlah sampel pasiennya masih terlalu kecil. Tapi ini bisa menunjukkan bahwa memang ada benefit. Benefitnya kita lihat adalah karena dia bisa mengurangi dosis toksisitas pada pasien kanker itu sendiri, lapangannya akan jauh lebih kecil sehingga pasien akan mengalami efek samping yang jauh lebih rendah. Tetapi kembali, saya selalu mengutip ini, kita bicara banyak penelitian, kita banyak bicara teknologi, saya suka mengutip dari satu film, salah satu aktornya quote-nya begini, "Impossible we do, miracle we try." Di era jaminan kesehatan nasional ini, ketika kita bicara antara ideal practice guidelines, kalau kita mengharapkan bahwa ke depannya PET CT akan jadi practice guidelines yang akan dikombinasikan dengan radioterapi masuk ke dalam guidelines nasional, kita bicara ada unit cost di situ, lalu kita bicara bagaimana dengan reimbursement-nya. Jadi kita memang sebenarnya apakah pertambahan dari teknologi, pertambahan dari terapi yang lebih ideal ini, kita mengharapkan terapi yang ideal pada pasien ini akan sesuai dengan kondisi dari negara kita sendiri. Sedangkan kita juga bicara satu hal, global competition, di mana mungkin di negara-negara luar ini sesuatu hal yang biasa untuk kita lakukan, misalkan PET CT yang rutin pada pasien. Kalau kita misalkan ngomong pada kasus-kasus yang tadi kanker, bagaimana pasien itu bisa dilakukan PET CT secara serial. Sedangkan kalau kita tahu budgetingnya, unit cost antara klaim BPJS juga tidak sebanding. Terima kasih.
In around about 35 minutes, and I think we have time enough to have discussions, or I can answer questions from your side. My presentation is today about FAPI, one of the new targets in nuclear medicine, and the question, of course, from all of you is it going to replace FGG or not? And what is the future of FAPI, and can we use it for cancer treatment? Well, what I will do is discuss a clear outline. I will start with a brief explanation of what cancer-associated fibroblasts are. Then I will move on to FAPI, its current value in clinical practice, and then the challenges we're facing, and especially when we talk about cancer treatment, do we really have a place or a role for lutetium FAPI in clinical practice? And hopefully with my presentation, I can end up with a recommendation or a conclusion or whatever. So let's start with the introduction. When we talk about molecular imaging, especially in oncology, I think you all know that FGG is one of the cornerstones in cancer imaging. FGG is a lookalike of glucose, a glucose analogon. And what you see here is that the uptake of FGG is comparable to glucose. However, the difference is that glucose is metabolized, whereas FGG is only metabolized in one step, and thereafter it isn't recognized anymore by the enzymes in cancer cells. Another important thing is that when you look at cancer cells, the expression of the glucose transporters is much higher than compared to the normal tissue cells. So a rapid intake, an increased expression of the glucose transporters in cancer cells is in fact the standard mechanism or the basic mechanism of FGG uptake, the increased FGG uptake in cancer cells. Another important aspect of FGG is that the higher the uptake, the higher the malignancy rate, and usually the poorer the prognosis is. And that correlation is well known and well described in literature. There are clearly established indications for FGG PET scanning. And when you look at the left side, the FGG positive tumors, we know that FGG has a clear established role in lung cancer, melanoma, colorectal, ductal breast cancer, high-grade lymphoma, and head and neck tumors staging, and also the identification of unknown primary tumors for these tumor types. However, you have to realize that there are also cancer tumor types or subtypes that have a much lower glucose metabolism and uptake, and that means that they can easily be missed by FGG PET scanning. And typical examples are the adenocarcinoma of the lung, where you can see faint uptake in a cloud-like lesion, prostate cancer, neuroendocrine tumors, but also the lobular breast cancers, the low-grade lymphomas, and the mucinous tumors and the renal cell cancers. And all these tumor types can be easily missed on the FGG PET scan. So the question is, has FGG a role in these tumor types? Well, that is always difficult, a difficult issue. Normally, we start with the FGG PET scan also in these tumor types, but I will show you in the next slides that we have for the FGG negative tumors better alternatives. One thing you have to keep in mind is that these tumors, when they become FGG positive, it's in fact a transformation to a more or a higher malignancy rate. So also in these tumor types, when you are able to visualize it with FGG, it means that they have an aggressive behavior and the prognosis becomes worse. Here you see an example of the two tumor types in breast cancer. On the left-hand side, you see the intense uptake in the ductal breast cancer, intense focal uptake, and that makes it easy also to find lymph node and distant metastasis. But on the right-hand side, you see a typical example of the lobular breast cancer. And we know from the data in literature that around 30% of the breast cancer of these subtypes can be missed by FGG PET scanning. And if the tumor is negative, it means that you are also not able to say something about lymph node metastasis or distant metastasis. So be aware, if the primary tumor does not show any uptake, don't say something about there are no lymph node metastases. It means that you cannot visualize them with FDG. Now, lucky as we are in nuclear medicine, we have currently new tracers, new alternatives for tumor imaging and staging. For example, in prostate cancer, we have PSMA, and I think the previous speaker, Ned Lenso, gave a clear overview of what's going on in the field of PSMA, PET scanning, and the lutetium or PSMA treatment. For the neuroendocrine tumors, we have as an alternative gallium dotatate or gallium dotanok. For thyroid cancer, radioiodine. Brain tumors, we have the amino acids. The low-grade lymphoma, the antibodies, and lobular breast cancer, we have alternatives like the trastuzumab and the estradiol PET scan. And finally, recently accepted as an indication is for renal cell carcinoma, girentuximab, the zirconium-labeled girentuximab. And for the hematopoietic malignancies, we have now gallium-68 pentixafor. And that means that for all the FDG-negative tumor types, we are able, apparently, to find alternatives for optimal visualization and staging. And it means that these targets, these tracers, in fact target specific aspects of the tumors. They are highly specific. They are able to target the specific features of these tumor types. Now, the problem is, even with the new tracers, we are still not detect or depict or visualize all the tumors. And what we know nowadays in literature is that there are new targets upcoming. New targets that are also present in malignant tumors. You can think about cancer cells. I just said that the alternatives like the DOTA-TOC and the DOTA-TATE and the PSMA, etc. But you have to realize that the tumor microenvironment also comprises normal fibroblasts, cancer-associated fibroblasts, reactive cells like macrophages, the lymphocytes, and finally also blood and lymphatic vessels are present in the tumors. And all these parts of the tumors can be visualized, detected with new alternatives we have in clinical practice. I will not focus on the immune system that is activated in tumor cells. So with the anti-PD-1 and anti-PD-L1, we can visualize what's going on regarding the immune response. But I will focus more on the cancer-associated fibroblasts, where in fact highly important for the malignancy grade of primary tumors. Now here you see the role of CAFs, of the cancer-associated fibroblasts in the tumors. And there are in fact 4 important roles related to these cells. The first one is that it in fact initiates the de-differentiation of the tumor bulk. So in fact it guides by some stimulative proteins the differentiation, and in fact it stimulates the higher malignancy grade of cancers. Another role is that it stimulates the angiogenesis. The angiogenesis, so the blood flow in the tumors. And that means that the better the blood flow is, the better a tumor can grow and metastasize. Another thing, and that is maybe the most important one, is that we know that the cancer-associated fibroblasts cause drug resistance. And that may be an explanation for drug failure, failure of chemotherapy or immunotherapy. So if we are able to visualize the presence of these CAFs and we are able to destroy these CAFs, we may in fact help destroy the tumors in combination with chemotherapy, immunotherapy, or whatever. But I'll come back to that later. And finally, it causes remodeling of the extracellular matrix of the tumors. And all these 4 components are in fact the basic principle of the malignancy behavior of cancers or tumors. Now, we thought in the beginning that there is only one subtype of the cancer-associated fibroblast, but we know nowadays that there are at least 6 of these subtypes. The matrix CAF, the inflammatory CAF, the vascular CAF, the tumor-like CAF, etc., etc. And all these CAF subtypes have a specific role or a stimulative effect in malignancies, in tumors. So if you talk about CAF, you have to realize that it can be different in each tumor type. Breast cancer can harbor the MCAF or the AP-CAF or whatever, whereas prostate cancer can show or harbor other subtypes of these CAFs. So be aware of that the heterogeneity of expression in tumors can be huge. Now, here you see an example of that. First of all, one of the basic questions also is, what is the origin of these CAFs? Well, it was initially thought that only a de-differentiation of the standard fibroblasts, the normal fibroblasts in cancers or tumors, were the basis of these cancer-associated fibroblasts. But nowadays we know that also endothelial cells or smooth muscle cells or adipocytes or pericytes, whatever, can differentiate or transform into these CAFs. And that means that the origin is completely different in one and the other tumor type. So the expression of the MyCAF can differ, but also the origin in the tumor types can be completely different. And you see here on the left side an example of the different CAF subtypes in breast cancer. You see the CAF S1, the CAF S2, the S3, the S4, and they all have different features. They all have different aspects on the cell surface. And the same holds true for pancreatic adenocarcinoma, where you can find the MyCAFs and also the ICAF and the AP-CAF. So it makes it unbelievably complex. So when you talk about CAF, you have to realize we have different subtypes, we have different roles, etc., etc. There is not only one CAF subtype. Now, when we talk about the visualization of CAF, the most important target on these CAFs is located on the surface, which is FAP, which is the activating protein expressed on the cell surface. And when we talk about FAP or FAPI, we talk about fibroblast activating protein inhibitors. And the funny thing is that we can label these protein inhibitors like PSMA or dotatate or whatever with gallium, fluorine, fluor18 or technetium. So that is the most important part of the cancer-associated fibroblast. But as I told you, the origin of the CAFs may be different in the subtypes, but also which CAF is expressed in the tumor types can be different between one and the other tumors, but also the FAP expression can be completely different on one CAF and the other CAF, or in one tumor and in the other tumor. And that makes it more and more complex about finding out what the real role of these CAFs and especially FAPI can be in clinical practice. Now, when we talk about FAPI, the fibroblast activating protein inhibitors, the fourth step in complexity is demonstrated here. We know PSMA has several different options, INT, the 617, PSMA 11. We have DOTANOC, DOTATOC, DOTATATE for neuroendocrine tumors. And when you look at the fibroblast protein inhibitors, you see that there are around 25 subtypes of these ligands available for imaging or maybe treatment of these cancer-associated fibroblasts. So be aware that also when we talk about FAPI, and you read the literature, start first with the identification of which FAPI is used. Now, the most commonly one used are FAPI 04 and FAPI 46. So when you go through the literature, you will find most of the data related to these FAPIs, and they can be labeled either with gallium, with fluor18, and even with technetium. And why is that with technetium so important? It gives the opportunity to find them like the sentinel node procedure. So you can use the FAPI to detect lymph nodes with a probe, and especially when labeled with technetium. Now, here you see an example of the standard distribution pattern. You see some faint uptake in the thyroid gland, the salivary glands, but also excretion via the kidneys into the liver. And the most important difference with, for example, FGG is that there is no uptake in the brains. So the skull should be, the head should be empty. And also you see in the abdomen there is some faint excretion in the bowel, and that is completely different to FGG. And that makes it a very, very nice option or alternative for FGG. Here you see a study that was done to find out what the most optimal timing was. And in fact, it is like FGG. After the injection of FAPI, it turned out that acquisition 1 hour after the administration was the optimal time point. So in clinical practice, we inject and do like FGG, a scan after 60 minutes. Another important advantage of compared to FGG is that patients don't have to stop their medication. So they can continue by, with using their drugs. Now, I told you that there are some different FAPI options, and when you look at the studies that had been performed to find out whether there are differences or not, you see in the upper row the FAPI 42 labeled with fluor 18. The lower row here are the gallium-labeled FAPI alternatives, FAPI 04. And when you try to find differences between a patient with lung cancer, it's just the left upper one, and the left lower one is the lung cancer patient, you see that there are absolutely no differences. So in fact what we know is that they share common features. So despite the fact that the molecules are different, they have in fact the same imaging features, and there are no real differences in clinical practice. And that makes it easy to pick out one and go ahead with it in clinical practice. Now, I told you that these FAPs, these cancer-associated fibroblasts, are found in malignant tumors. But these cancer-associated fibroblasts are also found in benign issues, entities. And these entities are fibrosis, kidney fibrosis, lung fibrosis, tumor fibrosis, fibrosis in the myocardium. So you have to realize, we always say that some traces are tumor-specific, like FGG. Also FAPI is not really tumor-specific. So keep that in mind. Also benign issues or entities may show FAPI uptake. Well, here you see an overview. I think you can't read it, but hopefully you get the handouts later on. But there are pancreatitis, adenoma, hemorrhoids, Crohn's disease, inflammation in the bowel, etc., etc. They all can reveal or end up with a positive FAPI scan. So be aware of that. Many, many benign findings may show FAPI uptake. There are some pitfalls. There are always pitfalls when we use molecular imaging techniques. And you see here an example, a premenopausal woman at the right side. At the right side, there is intense uptake in the uterus, whereas in the postmenopausal woman on the left side, there is minimal uptake in the uterus. So you see the differences in uptake between younger and elderly women. Be aware of that you get these pitfalls when you do a FAPI PET scan. Another example you see here, a woman on the left side, premenopausal, and depending on the phase of the cyclus, you see uptake diffuse in breast tissue. It is a pitfall. It is not cancer you're looking at or inflammation. It is just a hormonal status that may affect the visualization of normal breast tissue. And on the right side, you see a woman, the same woman, 2 weeks later in the cyclus. Now, here you see a patient, an example of a patient that has Hashimoto thyroiditis. And you see some diffuse uptake in the thyroid gland, and that is in fact in agreement or comparable with FGG. So also inflammation may end up with inflammation and with uptake, and the same holds true for fractures. We know that at sites of fractures, you see an increased FGG uptake, but also PSMA and also FAPI, well, are increased at sites of fractures. Here you see an example of a patient with myocardial infarction, recent myocardial infarction. You see the upper row, the perfusion scan with a large defect, in the anteroseptal wall, also in the apex of the myocardium. And when you look at the second row, you see that everywhere where the perfusion is diminished, you see increased uptake of FAPI. And that means that there is an activation of the fibroblasts. We can visualize that in the heart damage, ischemia. So also in the myocardial status, you may find uptake like that. With respect to the detection of bone metastasis, the question, of course, is what is the difference between FTG and FAPI? Do they have the same results? Is FAPI better? Is FTG better? Well, we know that also FAPI can reveal false positive results, and hopefully you can see it here at the right side. The left row, transversal row, you see an FTG scan, which shows absolutely no uptake in the spine. But when you look at FAPI, there is a small intense spot in one of the vertebrae. And that is not a metastasis. That's just a small nodule. So also these features or these abnormalities can show FAPI uptake. A study was published to find out what the difference is between FTG and FAPI with respect to the detection of metastasis in the skeleton. It turned out that FAPI had a 100% sensitivity compared to an 82% sensitivity of FTG. So apparently FTG misses some of the metastasis. The problem is, here you see a study in which they describe the localization of the metastasis. But the question is, which tumor types were included? And if lobular cancer, prostate cancer, etc., was also included, we know that these tumors can be missed by FTG PET scanning. And that means, of course, that FAPI reveals better results than FTG. Be aware of that. Now, what about the applications in clinical practice? You see here all the indications that have been published so far: breast cancer, head and neck cancer, pancreatic cancer, lymphoma, lung cancer, brain cancer. And all these studies nowadays are related to these tumor sites. And I think with respect to the indication that head and neck cancer is the most studied one nowadays worldwide. Well, here you see an example of one of the publications in literature in which all the tumor types have been described, in which FAPI may play a role. And you can see already, well, it is too much, and there is apparently something not right, or what are we doing? Because it's a non-specific tracer. Apparently we can visualize all tumor types, and that is not true. But we know sarcoma, gastrointestinal cancer, carcinoma of unknown primary tumors, ovarian cancer, neuroendocrine tumors. Well, all these tumor types have been studied so far, and you see what the result is. So be aware. I cannot go into detail into every study that has been published, but it is just to give you an overview on what's going on in clinical practice with FAPI. Here you see the differences that have been published between FTG PET. The upper row are the FTG PET scans, the lower row are the FAPI PET scans. The same patients have been studied. The left one is a lung cancer patient, and you see the difference in distribution between the FAPI and the FTG PET scan. And you see that apparently the FAPI PET scan depicted more tumor lesions compared to the FTG PET scan. And also when you look at liver cancer, it's one of the middle one. I cannot. Yeah, there it. Oh, there's something wrong. Yeah, there. That one, the middle one. You see there is intense uptake in the liver cancer compared to the FTG PET scan. So really, it's amazing what's going on with FAPI, and I think there will be indication where FAPI will outperform FTG. The most important question is, do we really improve staging? Do we improve the diagnosis? Do we improve progression-free survival and the overall survival by the new introduction of this new tracer? Well, what we at least know, and when you look at the right side, this paper has been published about the impact, the changes in therapy strategy that has been described in literature. The gray area, the lower one, means that the patient had a low-stage disease that hasn't changed. The upper gray bars show that patient had a higher tumor stage and that didn't change. But when you look at the pink bars that go up, it means that these patients were upstaged. And when you look at the green lines, patients were downstaged. So it means definitely that in this study it was shown that FAPI may have impact on tumor stage compared to the FDG PET scan. But whether it really improves overall survival or progression-free survival has to be established yet. Okay, I go. Now, I told you about the effects on patient management, and when you look at the data in literature so far, what we know is that, especially in head and neck cancer, it has resulted in adaptation of the radiotherapy field. And it changed because of more lymph nodes were detected in that area, and that meant that the area of radiotherapy, the field of radiotherapy, was extended. But the same results were found in radiotherapy plans of lymph nodes in the mediastinum and the pelvis. So we know that FAPI may end up with an adaptation of the radiotherapy fields. With respect to the distant metastasis, we don't know what the real effect is on the radiotherapy planning in general. Data are missing, but what we have seen so far, it is promising. And finally, what we have seen is, in general, the adaptation of patient management. It has been seen or described that systemic treatment has been altered into local therapy, a combination of radiotherapy and surgery instead of chemotherapy. Local therapy instead of systemic treatment. Local therapy changed to no therapy. Apparently, there were no metastases visualized with FAPI. And finally, in some patients, no therapy was changed into local therapy. And these are the results so far in clinical practice. But you have to realize that data in literature are upcoming and still not optimal. Well, you see here an example. On the left side, you see a patient with breast cancer, only one lymph node, and you see some uptake in the primary tumor in the right breast. When you look at the FAPI scan, you see that the tumor size is much larger compared to than visualized on the FDG scan. And also, when you look at the lymph node metastasis, there are even in the periclavicular region lymph nodes detected, which were completely missed by the FDG PET scan. And based on this, the treatment plan was completely changed. And here you see the value of the FDG PET scan. Here on the right side, you see the difference in uptake between the uptake of FDG in the primary tumor and the right side, the FAPI PET scan. Here also an example of breast cancer, but here ovarian cancer. We know that also in that tumor type, FAPI has shown promising results and in fact detected more lesions compared to the FDG PET scan. Now, also in non-small cell lung cancer and metastatic colorectal cancer, it has shown that FAPI detects more or depicts more lesions, and especially when there are peritoneal lesions, which are quite easily missed on the FDG scans, they were detected with FAPI. So overall, there are many indications in which FAPI may play a role. It may change patient management, but we have to prove that. Now, some final comments about the therapeutic part with FAPI. We know, like PSMA, we know, like dotatate, that also the therapeutic option is upcoming in literature. And it follows the theranostic concept. If we are able to visualize a tumor with fluor FAPI or gallium FAPI, the next step is to label the same FAPI molecule with lutetium or an alpha-emitting agent. So that concept may be applicable also to FAPI. However, you have to realize in literature we see case series, and I think it's too early to discuss all the results so far in literature. What do we know about FAPI? Well, in fact, you have to realize that when we talk about lutetium PSMA or lutetium dotatate, we target the cancer cell. And as a bystander effect, we know that also neighboring cells are killed. With FAPI, it's completely different because we're not targeting the cancer cells, we are targeting the neighboring cells. And that means that we destroy, by irradiation, the cancer-associated fibroblast. And hopefully, due to the crossfire effect, we also hit the cancer cells. But it will not be fully 100% as in lutetium PSMA and lutetium dotatate. So the overall effect of lutetium FAPI is expected to be less optimal compared to PSMA and dotatate treatment.
Excuse me, Prof. 2 minutes more.
Yes, I'm almost ready. What we hope is that due to the bystander effects of lutetium FAPI, we are still able to kill the cancer cells and not only destroy the cancer-associated fibroblast, but we're really looking forward to more data and to find out whether lutetium FAPI may have a role in clinical practice. What we think is that if we are able to kill the cancer-associated fibroblasts, which have a protective effect, in fact, for the malignancies, for the tumors, I told you in the beginning, the reason for failure of chemotherapy or immunotherapy may be related to these cancer-associated fibroblasts. Now, if we are able to destroy these cancer-associated fibroblasts with lutetium FAPI, maybe immunotherapy, maybe chemotherapy becomes more effective. So we think, with respect to FAPI, that combination therapies is the future and not FAPI as a standalone treatment. So there are still some challenges. I told you in the beginning, the heterogeneity of FAP expression, the heterogeneity of the CAF presence in the tumor environment. There are different FAPI radiopharmaceuticals. The question is which one is the best choice? Different radionuclides for therapy. Well, we have lutetium, terbium, yttrium, also the alpha-emitting isotopes. We still do not know what the best choice is. And there are also some general issues to resolve. We are still missing the phase 1, 2, and 3 studies in clinical practice with respect to therapy. Assessment of tumor response, which criteria are we going to use? RECIST or the PERCIST or whatever. We have absolutely no idea with FAPI what to do. Concurrent therapy for synergistic effects, and of course reimbursement. But you have to realize that this is an overview of what's going on. The lutetium labeled FAPI molecules, the yttrium labeled options, the actinium labeled alternatives, and also rhenium, samarium, copper, bismuth. There are so many alternatives currently studied in clinical practice. So if you want to make up your mind, well, have a good luck. It makes it very complicated. Now, one final thing. There are also alternative treatment options, so the non-radioactive treatment options that are currently under study. So we have the competition between the radio-labeled FAPI molecules and the other drugs that are really very promising. The direct targeting CAF molecules like FAP or the hedgehog signaling pathway, the paracrine factors, the reprogramming factors. I will not discuss them into detail because it's too complicated, but be aware that also the oncologists make steps forward. And if we want to be in the battle or in competition, we really have to collaborate instead of find a competition with each other. So also Indonesia, if you have started with FAPI imaging, help other clinics by implementing that in clinical practice. And the next step is move forward to the lutetium FAPI therapy and discuss the options with your oncologists. And I think that is one of the most important take-home messages for now. FAPI, it's really a good tracer. It is an innovation one. It was triggered by the FGG negative tumor types. You see, we are really happy with this new tracer. There's a peak of inflated expectations. We think that FAPI is the solution, but we know that FAPI has also false positive results and pitfalls. I think that in the upcoming year, we know that the real indications will be established, and that is not as presented now with an overview of used in every cancer subtype. I think that we are waiting for the real indications for FAPI. And finally, we get a plateau of productivity, and that is the moment where we get it reimbursed. Then the insurance company will help us by further studying the role of FAPI, and especially also lutetium FAPI. I think this is the last slide. I thank you for your attention.
Thank you, Professor Stockel, for the presentation, and we will start for second discussion. Yeah, we will please sit on the chair, the podium, and we will start the discussion.
Good afternoon, Prof. Stockel. I'm Junan from Darmais, National Cancer Center, Jakarta. I want to ask something about FAPI. As we know, FAPI does not directly target the tumor cell, but rather the area of tumor. In radiotherapy planning, in your slide, FAPI imaging in breast cancer, they show the wider area than FDG. FDG only one spot nodule, and then the FAPI is more wide. Does this mean that we might not targeting the actual size of the cancer? Would such approach be effective, or would it risk unnecessary radiation of the non-tumor tissue? Thank you.
Yeah, thank you for your question. The problem is, I explained to you all that FAPI, the uptake can also be observed when there is inflammation. So when you see much more FAPI uptake in a primary breast cancer, you have to realize that also inflammation may play a role. Be aware of that. Usually, when you talk about primary breast cancer, you also have the information of MRI. So for the delineation of the primary tumor, I think that you still have to rely on what is observed on the MRI. However, we know, and that's what I told you, that some of the breast cancer subtypes can be easily missed by FGG. So that means that small parts of the tumor can not be depicted by the FGG PET scan, but can be depicted by the FAPI PET scan. So the difference between inflammation around the primary tumor or real tumor size you see on the FAPI PET scan, yeah, be aware that nuclear medicine is not a standalone technique. You need other data or clinical information or whatever to find out what's going on. The only thing that worries me is that when you see the FGG PET scan with almost, well, a small part of tumor uptake, and you see only 1 or 2 lymph node metastases, and when you remember the FAPI part with intense uptake in a large part and multiple lesion also in the pediclavicular lesion area, yeah, that has definitely impact on your radiotherapy field, or maybe even on the systemic treatment. And that means that the combination of FAPI as a standalone technique, we still have to find out what the real value is. But I think that when you combine it with an MRI, usually patients have undergone already an MRI to find out where the primary tumor is located. If you can correlate it really with that imaging technique, if it's positive and all the lymph nodes in that area I described are also positive, you know that it's more extensive than on the FGG PET scan.
Sudah terjawab, dokter? Silakan para hadirin, jika ada lagi yang mau bertanya kepada Dr. Samuel ataupun Profesor Stockel, we'll wait the response of treatment with PET CT scan. And we are in Samarinda used to send patient to Jakarta, and there is a lot of cost. And in comparing to PET scan, how much the cost if later that FAPI will be the standard of treatment, if it more efficient or more economical than the PET CT scan?
That's
Thank you.
yeah. I realize that the costs of nuclear medicine are always a topic of discussion, and nuclear medicine is really expensive because of the price of the radiopharmaceuticals. We have the same discussion in the Netherlands. When you talk about reimbursement, the insurance companies do not a step forward but backward. That's where it starts with. And then they say, FGG, well, I think the real costs are now around 200 euros per gift. And with the new large big bore PET scanner, even not more than 100 euro. I think FAPI will end up in the same range with respect to the costs. I'm not so afraid of that tracer. Once it has been established, it will not be like PSMA, which is really expensive in our country. When the price is now around 1,500 euros per gift, per scan. Yeah, that's amazing. I mean, the insurance companies say, well, can we go back to the FGG PET scan? Hopefully, FAPI will be somewhere in between. But there is one comment, when you talk about the costs of nuclear medicine, if you are able to avoid surgery, chemotherapy, immunotherapy, or change patient management and improve overall survival, yeah, then the costs become relative. And especially what we know, for example, in immunotherapy, 80% of the immunotherapies fail. Only 20% have success. If you are able to select patients and say, okay, we can skip the 80% that do not have to undergo immunotherapy, yeah, if we can do the same thing with FAPI, improve staging, improving overall survival and outcome, it will completely change the discussion with the insurance companies. And I think it will change also what the patients will ask. I think that in 1 year or 2 years, patients will ask, is FAPI not an option for me? Mark my words.
Prof, I'm interested with your topic. I want to ask if FAPI now is your standard care in your center. And then seems like by the previous question from the audience that when we use FAPI, it seems like the tumors getting extended more bigger than when we use like FDG. Is it? So have you compared the result between the FAPI and the FDG and the result for like, we see the survival of patients and the, I mean like, seems like when you use FAPI, maybe the field of the radiation will be bigger, but we see that also the side effect, also the toxicities will be much bigger rather than we use the FDG. But how about the survival? I mean, like we see that is there any the progressive survival and everything compared between both FDG and FAPI in the treatment?
Yeah, that's a good question. Well, we still use FGG as the standard, the first step in clinical practice. So FAPI is not the first step in our hospital. However, when we talk about prostate cancer, neuroendocrine tumors, thyroid cancer, we use PSMA or dotatate or radioiodine or whatever. FAPI is a good alternative for FGG when the tumor is negative. And you have to realize that a PET CT scan is used for tumor staging. That's it, not for tumor characterization. The problem with nuclear medicine is that we are not able to say anything about the T stage of a tumor. So even with FGG or with PSMA or whatever, the real tumor stage is based on other techniques that have a better resolution than nuclear medicine. That is why we never say it is a T1 or T4 stage on the PET scan. So I think with respect to the tumor size and the tumor lesions, especially in breast cancer, sometimes a PET scan is performed earlier than an MRI. And then you have to be aware that FAPI may demonstrate more or a larger primary tumor compared to the FGG scan. And if you see much more lymph nodes, either in head and neck cancer or breast cancer, yeah, then you have to realize that you completely change patient's management. But the overall survival rates or data or progression-free survival, absolutely no idea what it will bring us. But hopefully we improve it all. And that has been established years ago for FGG. It was really a game changer in oncology, the FGG PET scan. I think FAPI will also be one of them. But as long as FGG is able to depict the primary tumor and you get an optimal staging, leave it as it is and keep it to FGG.
Okay, thank you, Prof. Tokel. Thank you, Dr. Samuel. I think it's nice discussion, but as time is go, and so we completely this session with thank you, Prof. Tokel, and thank you, Dr. Samuel. Kita ke sesi selanjutnya, silakan kembali kepada MC. Terima kasih.
Oke, terima kasih Dr. Stefanus. Acara selanjutnya yaitu penyerahan selempang manik dan plakat. Silakan foto bersama dulu, dokter.